Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Brad. How are you doing today?
I'm doing good, man. How are you doing?
I'm doing well. Reason why I asked you to come on is I heard a dirty little rumor that the fentanyl lollipops are going away, and it's getting replaced by the Sufentanil little Pez dispenser. So I guess the first thing I'd like to ask you is, one, is this true? And two, why?
It's a really good question, Dennis. Number one, I understand that to be true as well. I'm not sure exactly what drove the drug companies to stop producing the lollipop. But typically when you see things like that, there's been lawsuits involved and things along those lines to where the company decides, I guess one way to put it, the juice ain't worth the squeeze anymore to keep producing it. And we always have to remember that even though in the military, we think like everything's made for us, right? Really, those things are made for the civilian market. And that's where, the cost benefit ratio really comes into play for companies that are producing these things. So I'm guessing at some point they decided that they could no longer produce it and it made sense for them to do it. So I guess that's where we're at now. Switching over to the Desuvia or the Sufentanil, little sublingual or, buccal type tablet now with the little dispenser seems to be the way that people are choosing to move for the military side of things, from what I'm understanding as well. And so I think that's where we're at least, for the moment that, they've decided that this is the way we're going to go. And, so let's look at what that means and what are the pros and cons of some of those things, if we're moving forward in that direction. So, yeah.
Yeah, absolutely. So, Sufentanil, as I understand it, is just another analog of fentanyl, but spelled different. So obviously it's not the same. What are the characteristics of Sufentanil? Is it stronger? Is it weaker? Is it something extra special about it?
So, interesting, when we talk about narcotics a lot, I always look at it as I kind of look at it like cars in a way. It's like once you move into the fentanyl family, it's almost like, okay, I've moved up into the, Mercedes-Benz class of opioids, meaning that it's a synthetic opioid. And what they have done is, created different types of fentanyl, that have different characteristics, to treat for different types of conditions that, patients may have. And so when you get into the fentanyl family, you'll have fentanyl, which was the baseline for, all of them. Sufentanil, which actually the injectable version came around in the 1970s. It's about 5 to 10 times stronger than fentanyl. That's the easiest way to think about it. Some books you read, it's like 5 to 7 times as strong, but it's kind of easier to remember. It's somewhere in the middle, between 5 and 10 times as strong as fentanyl. Its characteristics are very, very similar to fentanyl. But almost like the name sounds, Sufentanil, it seems to be a little bit more even smoother than actually fentanyl. And what I mean by that is, it's very effective at blocking, the sympathetic response to things like surgical incision and intubation and things along those lines. It is a very, very powerful, narcotic. And is very specific that works at the mu receptor. So it is incredibly effective, a little more expensive than fentanyl. But again, the characteristics are almost identical in terms of like very fast acting, injectable wise, within about 60 seconds, last about an hour. All those kinds of things come into play. typically in the hospital environment, even sufentanil was, almost reserved for a long time because it does cost a little bit more you would almost need a reason to use it more than fentanyl, I guess is a way to put it, because other than it being like more powerful and a little bit smoother, it does cost more. So a lot of times people would still just use fentanyl even in the hospital. But for things like cardiac surgeries and surgeries where you absolutely wanted to make sure that you weren't getting an increase in sympathetic outflow to stimulus, sufentanil was always one of the better choices that people would switch over to in those environments. The other thing about sufentanil too is that it would come in that 50 microgram per ml dose, and because it's so much stronger, you could, in your bag, technically carry less of it, and then you would dilute it down. Now I'm talking IV again, to use in the field. So, even early on when we were, introducing fentanyl, to the medics and, in the injectable form, we even looked at, using sufentanil because you could carry the smaller package and get more bang for your buck out of it that way. But again, because it was more expensive, it's not as readily available. You do have to dilute it, for what we were doing, with it. It just kind of didn't, make sense. So pretty much it was hard enough to get fentanyl, going at that point in time, getting people to understand that, it really was better than morphine, especially in the trauma setting. But that was almost a bridge too far for a lot of people that just weren't accustomed to using it. And so then if you say, oh, here's sufentanil, which is 5 to 10 times more powerful, everyone's like, oh, no, let's not do that yet, kind of thing. Interestingly enough, though, in that mix of things was when the lollipop kind of started to become the fentanyl lollipop, Actique, started to become something that we were looking at that all of a sudden we found that was a, non-injectable, easy to administer, type of a narcotic in the field environment that was really, really effective. And so I think most of people's introduction into the fentanyl family, as far as dosing people from the medic side of the house, was, the fentanyl lollipop. And good Lord, I mean, in the U.S. military, it became pretty ubiquitous, everywhere. So that it's going to be interesting now that we're saying like, oh, now we're going to take that away from you, here's your next option, which, okay, sufentanil, which goes back to what I was saying before, I could see where people right out of the gate would be a, whoa, okay, but, again, incredible drug, very similar to fentanyl itself, other than it being more powerful than fentanyl. But again, incredibly effective. So, yeah.
So when they made fentanyl to begin with, they removed a vast amount of that histamine response. So you really didn't get as much like the vasodilation, the histamine response that you would with morphine and even hydromorphone. Did they make any real tweaks or any kind of changes that you would notice with the sufentanil versus the fentanyl?
Other than the fact that it's more powerful, not really. I mean, I know we could, there's some PhD somewhere getting angry right now, this says like, whoa, okay. Not too much. I don't think really you're going to notice anything, other than the fact that, if fentanyl is a respiratory depressant, which it very much is, sufentanil is going to be more so. Okay. And one of the, exactly. So, just because of the fact it is more potent, but the other thing that you can see with sufentanil versus fentanyl is you can see bradycardia with fentanyl, but with sufentanil, you can see even a little bit more bradycardia. You might see some hypotension with it, depending on how volume depleted your patient is, things along those lines. But those would be the two things that, as people are making that switch from fentanyl to the sufentanil, if I'm teaching people about it, I would just say like, hey, really key into respiratory rate and look at what their heart rate's doing, because you might see a little bit more of an effect with the sufentanil. The other thing is you might see a little bit more sedation with sufentanil than you do fentanyl. But again, the problem that we're dealing with here is that when you're not administering it IV, you're administering it through the mouth, meaning that it's absorbing, in the tissue in the mouth, that uptake can be incredibly variable between patient to patient. So that's why I always just warn people. I'm like, hey, look, these are two big things to key in, right off the bat, when you're giving them that. So yeah, I would say, without getting into some massive pharmacology side of the house, again, they're incredibly similar. Just one's way more stronger than the other one. So yeah.
Okay.
Yeah.
Now, when you're talking about seeing, more sedation, more respiratory depression, potentially more bradycardia, you're talking about like equal doses because sufentanil is so strong.
Yeah. I mean, so what I'm really saying is, even if you kind of equate it out, that sufentanil, I would just keep people in. I don't get too caught up on the exactness of it. As just kind of like I'm moving from something that's less potent to something that's more potent. And these are kind of those areas that you may see that if they are absorbing more than you think that they're absorbing, because it is a more powerful drug. That's really kind of the way I'd look at it, and not as much as like this is an exact duplicate of this, which even then you're going to see a little bit more bradycardia at times. Not a lot, and again, it depends on what's going on with your patient, but it's just very good at blunting that sympathetic response. And so you're really, if the heart rate is staying up because they're in pain and you're taking that away, you know what I mean? Even more so, even better than with fentanyl. Well, yeah, you could definitely see the heart rate drop because, the pain was driving the heart rate at that time. So yeah. That's kind of how I look at it for people. So yeah,
absolutely makes sense. Now, I would imagine for the vast majority of people, at least this the sublingual tablets is the only way I've seen it come out. Like you mentioned, the IV version of it's been around for a long time, but I've only seen it in the sublingual. This is just going to be a tab under the tongue versus like a fentanyl lollipop. What's the give and take with that?
Well, so again, it seems like they've settled on the 30 microgram tablet. That's basically, and it's not really under the tongue as much as between the cheek and the gum, like the lollipop, very similar. And I know, it's supposed to kind of turn the mouth kind of this bluish purple, if you've put it in the mouth, so that I guess in a way that like in a field setting, you can say like, oh, well, they've had one, and you're not supposed to redose it for at least an hour, when you give it. So at least hopefully that's one way, that you can tell versus, the lollipop actually hanging out of the mouth. The biggest thing I would say is, early on, back when the lollipops were around, we also had sublingual or the tablets of fentanyl. And it came in, I think it was 100 micrograms, 200 micrograms. It also had a few different dosages, kind of like the lollipop. But early on, most people decided they didn't like using the tabs because, they're small, and in the field environment, it's very easy to drop them, lose them. And whenever you're under a lot of stress, your fine motor skills are out the door anyway. So here you are trying to hold on to this little tab and, get it into their mouth and not have them swallow it. And how fast are they absorbing it? And then, if you had multiple people and, who got one, who didn't, kind of all those things that we're talking about here. The other thing is like, keeping track of them was a pain, to be honest, because it came in a little vial, and there's a lot of them in the little vial, and counting all those was just nah. Anyway, so the lollipop really became the way to go. And the other really great thing about the lollipop still is that, if someone started to become a little bit respiratory depressed that you didn't like, or, it's the old Ranger PCA pump, you tape the lollipop to the finger. And as they became more sedated, and the lollipop would come out of their mouth, and then it'd start to wear off, and they'd kind of wake back up and, oh, it's still on my finger. Let me put it back in my mouth. You can't do that with this, So when you put that tab in there, there's some things that, you're losing track of. Okay. One is, how much are they actually absorbing of the pill? How are you going to fish it out of there if you feel like this guy's, getting too respiratory depressed? How do I go in there and get it? I told you before, I'm not a huge fan of ramming my finger in anyone's mouth that's like half awake, that doesn't know what's going on, The other thing too is swallowing the pill. That's another biggie, and I know that we've all, with the lollipops, you've always got that one where you're like, hey, put this in your mouth, rub it back and forth. Don't chew it and swallow it. You've already got the one guy who's like, doc, I'm hurting. And they bite it and they swallow it, like, okay, well, you're out of luck, dude. You know what I mean? Because it doesn't work as well. Well, with the tablet, if they swallow it, they're only getting, I think the number's like 9% is all that you're getting. You know what I mean? Because so much of it, when it's absorbed through the stomach, the first pass effect runs it through the liver before it ever goes out to the body. And most of that gets destroyed in the liver, and you hardly get any of the drug at all. So now what do you do? It's like, oh, they swallowed it. Their mouth's not really that blue because they didn't suck on it. They actually swallowed it. And okay, do I give them another one? Do I, are they just SOL at this point? What do we do? So, I mean, again, I hate to, flog a dead horse here, man, but that's one of the reasons the lollipops are great. You could take them out, you could put them back in, it just, in a field environment, had a lot of great things about it. That, not saying that, you can't work through these issues, but you better think about them, because I guarantee you it's going to happen. The first dude you shove a pill in their mouth and be like, yeah, just, keep it back between your cheek and your gum. And they're going to be like, ooh, and it's gone.
Swallowed it.
Yes, and it's gone, So, okay, yeah. I'm telling you, it's going to happen. You know what I mean? So,
well, I mean, I'll open this up while we're chatting,
yeah.
But so have you used those sublinguals yet?
Not the Sufentanils. I did use the, on casualties, I shall note, not me personally. These days you gotta be specific. But yeah, we did use the tablets some. But like I said before, it was kind of like, there's just a better way to go. And, so we had them early on, but it was like, we got better options, kind of a thing. So,
right.
Yeah.
So this is the little dispenser.
Yeah.
And let me see if I can put this close enough. That little white dot is the actual pill.
Mm-hmm.
It's really, really tiny. But so the whole idea, it's got a little adapter. You take this off and very carefully you stick this in the guy's mouth and you push this plunger, and I just dropped it.
Exactly. But out it comes.
Holy cow. This thing is incredibly tiny.
Right.
Yeah. Like people are going to drop this, and I think it's going to be laughable if you got your combat gloves on picking this thing up.
If you could find it, even.
If you can freaking find it.
Yeah.
But how long? So obviously everybody's different. Every trauma is different. Mm-hmm. You know, you got a gunshot wound to the arm or the leg or something relatively minor. You know, physiologically, people are relatively normal. Mm-hmm. Compare that, like, oral absorption versus, you know, somebody who's actually sick and, you know, I'm giving like the same, I imagine it's the same with the fentanyl lollipop. It just takes forever. The sicker they are, it just takes longer.
Sure. Yeah. And again, you know, even if you're not trying to swallow portions of it, some of it gets in your saliva and you swallow that saliva instead of it actually being absorbed. And I think if I remember right, we're looking at before on the fentanyl lollipops where actually even the lollipops, I think it's only about 25% was actually absorbing through the mucosa in the mouth versus, you know, it was getting swallowed through the saliva and things along those lines. So you're going to swallow parts of it, but, you know, typically it should start working within a few minutes, you know, as long as their circulation is normal. And the other thing you do have to kind of watch for is if their mouth is really, really dry, they won't dissolve the pill as quickly, you know, and so the uptake's going to be a little bit different as well, you know. So
would you give that guy like a drink of water?
I knew that was coming, dude. You're going to back me in the corner now, man. So, I would recommend that if you give them a sip of water, they swish it in their mouth and spit the water out. Because now we're getting into like NPO status, going to surgery. And, you know, I know we're splitting hairs here, but, because if you hand a dude water and you're like, here you go. And they're like, go, you know, and they start hammering the bottle of water, then you're like, oh God, you know. But yeah, it's like sometimes you got to give them something in their mouth to wet their mouth, you know, to, you know, get some saliva going. I mean, even the fentanyl lollipops, you know, were that way. But at least the lollipop, since you had the handle, you'd have a guy move it around like they're kind of brushing their gums with it. And that would actually stimulate some of the saliva to kick back up. And could help them out that way. Whereas, you know, with the pill, the size of that thing, you're not going to do that. Yeah. You know, so yeah.
You're not going to even recognize this is in your mouth.
Yeah. So
I don't think.
Yeah. But yeah, if their mouth is really, really dry, then you're not going to get the uptake quite as good as, you know, if they got kind of the normal mucosa, going in there and it's moist and it's starting to absorb it up through the system. So yeah. Again, it's just one of those things that, you know, you just don't think about till you start to see these things in the field environment versus a hospital environment, you know, type of a deal. So,
so they settled on the 30 microgram.
Mm-hmm.
Okay. At least the study that I read from the NIH, they did a placebo. They did 20 micrograms. They did 30 micrograms. 20 acted as well as placebo, so they went to the 30. Mm-hmm. So if I had to guess, they're kind of aiming for the low side of effectiveness, mm-hmm. right?
Yeah, so seems like it. Yeah.
So to me, that tells me like I'm probably if I got somebody in real pain, I might have to dose them on top of this
mm-hmm.
and now I can't give them another pill. Right?
Not by the book.
Not by the book.
Yeah.
So I mean, what would you recommend? You know, I got Sufentanil, I got IV fentanyl, and I got ketamine.
Yeah. So you're getting me in trouble again. I knew it. Well,
you're retired. It's
okay.
Yeah.
You know. Well, so again, you know, this was one of those things where early on we were also trying to develop, you know, the ketamine nasal spray to deliver like a low dose ketamine dose to then enhance the effect of any narcotic that you were going to give somebody. And this brings up another reason why that would be, you know what I mean? Because you're right. So if you do the numbers and you say 30 micrograms for the sufentanil tablet, then the thing about that would be is if you multiply that out, well, you're about 150 micrograms of fentanyl tablet or lollipop, I guess is the way to put it. Even if you go on the high end of that, you would be at, let's say it's 10 times. We use that number. You're at 300 micrograms. Okay. So again, in the beginning with using fentanyl lollipops, we had the 200s, the 400s, and those lower dosages really didn't work well at all. And we settled in on the 800s was where we settled. So it would not shock me using that dose, and depending on how quickly they take it up through the mouth, that, with some of the more painful type injuries, like one of the ones that I saw quite a few times that was incredibly painful, not exactly life threatening, but was if someone had taken a penetrating injury through the femur and shattered the femur. Even different than like a jump injury. You've seen broken femurs on the drop zone. Those are bad enough, but there was something about, like a rifle bullet passing through and shattering the femur is just like, wow, getting that kind of pain under control was a lot of times pretty tough. I would venture to say that that Sufentanil tablet, in the mouth at 30 micrograms ain't going to be enough, and it is going to force you to do things like, okay, if I don't have IV access, can I now just go ahead and give them some IM ketamine to, help the Sufentanil help, enough, to get them to that next level of care. So, yeah, I think it's going to, again, I think it's going to be interesting the more that it's used in the field environment to get the feedback from everybody to say, yeah, it's working, or, hey man, we got to alter the TTPs here. Maybe it's one, and then in 15 minutes, it might be another one, based on what we're seeing with these type of injuries, type of a deal. And again, I'm not advocating one or the other, so to speak, but I hope people don't just take the book answer and stop, and be like, well, it just says we can't do it. It's like, yeah, okay. But that's not where the story ends. We need to, that's chapter 1, chapter 3, 4, and 5 are probably going to dictate what this book looks like. You know what I mean? Moving forward with it. So, I think AARs, I think those are going to be crucial, like early on, and again, it's not like we're seeing all the casualty numbers that we had to get us good numbers. I think it may start out being things like this happened on the drop zone and those types of things to start, but those are going to be just as important, to start to collect our own data. And you guys at the schoolhouse, you're going to hear the guys coming in talking about it, when they come through refresher and things like, man, that didn't work. You know what I mean? Like I had to bust out the ketamine and then it worked, that kind of a deal. But, yeah, I think it's going to be interesting, but it's going to take time to get some feedback.
Yeah. I think, just as a community, we're not very good at practicing giving narcotics. Like we're just not like, and I understand, like, one, there's a danger in doing it.
Sure.
Just like there's a danger of going to a rifle range, but
right.
We do that.
Yeah.
But guys just getting comfortable with just some basic principles of, administering narcotics and having that kind of foundation down, I think would make everybody a lot more comfortable, especially when they're introducing a new narcotic. Mm-hmm. If, just a basic understanding of, I need my full mismade in my bag.
100%.
I need to actually assess the patient. There is no, one shot, one kill with any narcotic. You're going to either overdose or underdose with that first one. And how do you adjust fire? to get what the patient needs, in a safe way. I wish that was a lot more common.
100% agree. We've chatted about this, multiple times, used to, when I was still active duty, we had certain rooms up in the operating room where, we could get, the guys to come in for a day and they could see, and participate in multiple types of, sedation cases. And, that kind of trigger time with those types of drugs, back then it was, using Versed, ketamine, and fentanyl, and using it multiple times, it's really what it takes, kind of back to the analogy of going to the rifle range. If you go to the rifle range once a year and you get 30 rounds, you ain't that good. Not unless you're doing stuff on your own. You know what I mean? You can tell everyone how great you are, but let's face it, that is not mastering the basics. You know what I mean? But the more time that you get and the more exposure you get to actually different types of rifles, you start to understand what's used for what and what makes sense, and especially if someone were to come in and take your M4 away and say, we're not making these anymore. You cannot have it anymore. We're taking that. These don't exist anymore. Here's this 22, long rifle, round, and if you never shoot it, out of the gate, you're like, that looks different. You know what I mean? But if you never get time, shooting it and be like, hey man, this sucks. Like, you know what I mean? Like, we got to do something different. You know what I mean? Well, it's kind of down those same roads, you know what I mean? Or, someone gives you an AT-4 to shoot at a bunny rabbit, you'd be like, that was too much. You know what I mean? So it's somewhere in between. But back to your point, it's important not to just trust other people to give you this new thing and then to put into your bag and it's going to do everything that they tell you it's going to do, because we've all learned that one the hard way, but there is some good stuff out there from a lot of people that have done this kind of stuff for a long time to learn from our mistakes. So you don't have to repeat it, to be able to say like, okay, at least here's your starting point with these things. And here's a lot of the things you should consider, so that if you do see some of this popping up, you're not starting from scratch, you'd be like, okay, all right, this is all I've got, but let's write this down. Let's talk to people about it. And, how do we move forward? And can we change the TTP some so that the casualty is not suffering, cause if I had a broken femur and the guy says, well, you've had your one pill, you know what I mean? Like, yeah, I'm reaching for my bag, you know what I mean? Like, or their bag, it's like, this isn't working, so, but yeah.
Another thing in that research paper was, 72 hours was like repeated multiple times, that you cannot give this for longer than 72 hours. So, does the guy burst into flames? Like what,
no.
What happens?
No, again, it kind of goes back to the protocol and the worry of building an addiction to it. Because it is so powerful that really, any of the narcotics, I would say the recommendations, if you look at any of them, is like, you have to reevaluate giving this longer than a 72-hour period to somebody because of the risk of developing an addiction to it. And if you think the addiction to morphine is bad, the addiction to fentanyl is a lot worse, as unfortunately the general public is seeing now. Sufentanil is even more powerful. You know what I mean? Which brings up another kind of sidebar note, is like the problem a lot of times with, I always get the question, I have to stamp it down the minute people ask as well. If I'm in another country and I don't have, the fentanyl, can I go buy stuff off the street and use it in a pinch? And the answer is absolutely not, because a lot of what we're seeing, like in the civilian world now of the fentanyl crisis is a lot of those fentanyl tabs that are being purchased off the street aren't just fentanyl. It's actually a combination of like fentanyl, sufentanil, carfentanil, which is incredibly powerful, like elephant tranquilizer stuff. You know, I'm not joking on that. You know what I mean? And then people are overdosing on it, but it's actually not just fentanyl. You know what I mean? So again, you know, anytime, you're talking that 72-hour window, really what they are saying is you got to reevaluate why you're giving it, or could we switch out with something else that could be effective now that we're past that initial trauma, so that I don't run the risk of the person, becoming addicted to the drug long term, you know, so that's, you know, anytime you see a study, they're normally going to have like a window in there. And that one was the 72 hours. Hey, no, they're not going to burst into flames. You can keep going with it, but you're going to raise the risk that they could develop a, kind of a long-term addiction to the drug the longer that they're on it. So, yeah.
Okay.
Yeah.
So just having worked in like a burn ICU,
Mm-hmm.
I know with just regular fentanyl, they were talking like 72 hours ish, wanting them to come off the fentanyl,
Mm-hmm.
because of metabolites is what they kept saying. So is there anything special about these metabolites?
Well, I mean, so, normally what they're talking about is, on a drip. Okay. Normally, or like a PCA pump or what the one that was really nasty years ago was, Demerol. Demerol actually had an active metabolite, and that would build up. And so after 72 hours, people were having things like seizures and things along that line. Normally what starts to happen with fentanyl is it's a curve when they're on a drip for, 24, 48 hours. And that curve kind of goes up and starts to flatten out, where it's like it's building up in the system is what it's doing. And so you don't want that. And that's why, like, normally after that 72 hour kind of window, you would look at it, and sufentanil would be the same way, you know. Back to the family of fentanyl, there is one of the other, drugs in the fentanyl family called remifentanil that is specifically made. Now, it's very expensive and very specific, but it's made, because it works very fast. It's made for an IV drip. And the minute that you turn it off, it goes away in minutes. It's chewed up by plasma esterases, which is different than like sufentanil and fentanyl. But again, back to kind of what your question is like, you know, you just don't want to keep them on it. If you're going to have to alter the dose eventually is kind of what they're saying. We can't just set this up and leave it for a few weeks and everything's going to be okay. It's going to start building up. So, yeah. Sure.
Now, especially since this is a prolonged field care podcast, and some of these, especially the guys going to AFRICOM and I'm sure other places, they're looking at like 96 hours to get somebody moving on out. So, you know, you got, a handful of these things. For whatever reason, you can't get some kind of IV or IO access. I don't know why, but let's just say you couldn't. How would you transition off of this to something else? And would there be any specific choice? Let's just say you carry what you normally would carry.
Well, I think what you're saying is like, do I run out of them? Is that what you're saying? Like,
no, let's say like I got a handful of them. I got enough for hours and hours of just dropping these. But I know like, hey, that 72 hours is creeping up. And I would like to transition off so that I don't just use all of my, sublingual tablets. And I want to transition somebody from one narcotic to another narcotic. Like, how would I go about doing that?
Well, typically what you're kind of describing is like, okay, I've got a stable casualty that I have to treat pain for a long time. And so now I'm not worried about like they're severely hypotensive or or things along those lines. I'm just worried about long-term treatment of pain. That's whenever you really do kind of switch back and say like, okay, now I could transfer or switch over to morphine, which is more long-term, or dilaudid hydromorphone, which is, again, long-term type of a deal. And so what I would do is just, now you got to remember, normally the Sufenta is wearing off kind of in that hour window. It's a little bit different when they're absorbing it through the mouth, but even then, once it's been like hour and a half and their pain level's starting to trend back up, well, then I'm going to start titrating something like morphine or hydromorphone, whether it's IV or IM, so that they don't lose all of their pain relief all at once. And now I'm trying to get it back under control. You don't want to do that. But I could start at those lower dosages, and I could use, like, again, IM or IV, depending on what my access is. And then I'm not having to dose something every single hour. Now I'm using something, I'm saving my Sufenta tabs that way. And this makes sense. That's always the thing. I talk to people a lot about use the right drug for the right situation. Because sometimes people get so locked into, well, I started with the Sufenta tabs, I have to stay with it. It's like, no, you don't. At some point it makes sense to do exactly what you're saying to make that transition. And so, they're stable. I don't have to worry about the histamine release with the morphine, yada, yada, yada. Yes, I'm going to switch over to like the morphine or dilaudid if that's what I had. And now I can treat them every, maybe it's 3-4 hours that it lasts. And, I can save the Sufenta tabs for the next guy. Yeah. Kind of a deal. So, yeah. Sure.
So at least when I have it in my head, let's say I'm targeting a pain, 0 to 10, let's say a 4 or 5,
sure,
something like that.
Sure.
He's not zero pain, mm-hmm. but he's comfortable enough, mm-hmm. right? Mm-hmm. We're getting back to somewhere more stable. Patient is at least quasi-stable enough that I'm not super worried about his physiology. I want to transition. Let's say we're doing morphine, mm-hmm. right? Maybe start off at 2, 3, 4 milligrams and just kind of see what happens as he's going from that 4 or 5 to more like a 6 or 7.
Sure.
And hit him with a small bump and just kind of step back and see what happens.
Yeah. And I always tell people, like, when it comes to dosing your narcotics, my number one thing, especially in the field environment, is to look at respiratory rate. It's not always a great thing to ask them, hey, what's your pain level? Cause, patients lie. You know what I mean? It's like, it's 10 out of 10. And like they're asleep. You know what I mean? Like you wake them up and 10 out of 10 and they go back to sleep. Like, all right, what's their respiratory rate? That's really where I'm looking, and so if they are less than, if they're less than 8, I'm not giving them anything yet. Typically if they're in that 8 to 12 range, maybe even 8 to 16, I'm pretty happy with where they are. It's when they start trending up towards, 20 that I need to get that back down into that 8 to 12 range. So anytime, especially if I'm making a switch over, I'm waiting for the respiratory rate, to start trend up a little bit. Then just like what you're saying, especially if it's IV, all right, let me give them 2 milligrams of morphine right now, IV. Let's see what the respiratory rate is in about, 10 minutes. Cause you got to remember, you got to let the morphine peak, and then you find out like, oh, they're breathing 10 times a minute. I like that. I'm going to stay right here. I'm going to hold on to the rest of my morphine and let's see how long this lasts. Is this, you might find out it gives you another half hour before you got to do anything, but again, I'm looking at that respiratory rate as my gauge to decide, do they need more? Are they okay? And that really, especially in a field environment. That's really the key that I look for. And I'm talking about respiratory rate. Like people get wrapped up around a pulse ox and like, no, I'm talking about literally what's the respiratory rate, because people read pulse ox wrong and they get lost in a number, and they're staring at it and you're like, dude, just tell me how many times a minute they're breathing, and we'll base everything from there. You know what I mean? So, yeah.
Yeah. And I also think, with morphine and even hydromorphone, what probably people like me is the patience part. We want like instant gratification. Like you push that plunger, I want them to land exactly where I want them to be. And I got to wait 10 whole minutes.
Oh, yeah. Well, and again, early on when we were, I was teaching the guys with ketamine protocols and sedation protocols that we were developing. That was one of the big pushes to get away from morphine in that immediate time period, because fentanyl works IV now 60 seconds, and it peaks within like 2 minutes, so you are getting almost that instant gratification of, are they where they need to be? Do I need to give them more? Pretty quick, because all of us are type AA, and just like what you're saying, it's like, I ain't got time to wait for this. I got to go, and that's where people would get in trouble with morphine, because, it can take 3-4 minutes for it to start working IV, and it won't even peak for 10 to 15 minutes to see what the full effect is of the drug. And so people would redose it, because they're impatient. They redose it again. And then 15, 20 minutes later, like, why'd they stop breathing? You're like, they just got all the drug. That's right. I didn't have anything to do with it. There's something wrong with this morphine. It's like, yeah, no, dude. Yeah. So that again is funny, but it's like, that was why taking people into the operating room, seeing sedations, how fast the fentanyl worked versus morphine, to get them to say like, okay, this makes a lot of sense to use, especially early, especially if I'm doing procedures. That's why it was so much better of a drug. But just like you described before, it's like once the procedure's over, they're stable. I'm just worried about long-term pain control. Now I really can switch over to the morphine or the hydromorphone, and it makes sense, because it's going to last a lot longer and keep them comfortable. So, but, again, like we talked about before, you got to think, you know what I mean? It's like, I know everyone wants a cookbook. If I just do this thing and it's fire and forget. No. It's not. Sorry. You picked a profession that, you have to make a lot of decisions based on imperfect information, and you have to reassess. You can always give them more, like I've always said. And I'm pretty sure there's medics waiting out there. Once they go to my funeral, they're going to stamp titrate to effect on my tombstone, because they've heard me say that so many times. But that's where that really comes in, man. Absolutely. Yeah.
So you taught the medics to say titrate to effect?
Absolutely.
You probably should have told the doctors to ask them, what effect are you looking for? Because
well, actually, I did.
Oh, good.
Yeah, because like I said before, the other part of that was respiratory rate. And so when we were working on those, is titrating to the effect. The effect is it's multi factorial, but the one up front is I'm titrating to that respiratory rate that I need, because what they found out is most of those other things fall into place if the respiratory rate is down at that level I need it to be. Oh, look, their pain's actually under control. Oh, they're actually holding still for the procedure. Oh, all those other things are falling into place, because that was such a good gauge, in a field environment. You got to remember where we're working and everything. But yeah, no, it should have said on the front part of my T-shirt, titrate to effect, and on the back, respiratory rate. So that would have that would have solved it. Yeah, for sure.
So as DoD transitions to these little things, both for the medics and probably the people training the medics, what advice or what things should they be practicing before we really go live?
Oh, you mean like, hey, we're gonna go in the team room today, and we're gonna go through this, and well,
that would be awesome. Yeah, but I don't think that's gonna happen.
Okay. Well, I would advise that first. Okay. Like, let's go talk about what this drug is, what it's like, how it compares to the fentanyl lollipop. What's the proper, how is it, being used correctly? In other words, in between the cheek and the gum, the mouth being, relatively, moist so it can absorb it better. Talk about those kinds of things, what to do maybe if they have a dry mouth or something along those lines, and talk through some of those other parts. What am I looking for? Just like we're talking about right now. How do I actually know this thing is working? So cause and effect. I'm given this. So what do I want to see to know that this thing is working, that I don't have to do anything else at the moment? Kind of a deal. When do I redose it? Like we were talking about before, what's that protocol look like? What you don't want to have happen is guys that are in the field with something new guessing, and they're under an incredible amount of stress and pressure in that moment that we've all been in that moment. I don't want to be making it up then, cause somebody's going to make a mistake. You know what I mean? And the sad part is they're going to get blamed for it, and really, yeah, of course. If you go backwards, really who ought to be blamed is whoever was training, and didn't do those things before they just, said, here, it's like a lollipop, do this and go out and do great things. And like, yeah, no, that's not a thing, dude. And I would also recommend, honestly, that the guys who are doing the training, they go get the training first. You know what I mean? Because all too often they'll just read something and be like, oh, okay, well, here it is. And then they're not really set up to be training other people either, and then, so it just, it kind of, one mistake leads to the next, and then there's a wreck. You know what I mean? And then everyone's shocked whenever there's a wreck. And it's like, well, they didn't have a driver's license. They didn't have insurance. They'd never driven in their life, and you gave them a Ferrari and the keys and said, yeah, go knock yourself out. I can't believe you wrapped it around a tree. Well, okay. I'll show you my shock and awe face sometime if you want to see it. But we joke, but a lot of times, it's what happens, in a different kind of a sense. You know what I mean?
Well, I mean, not to jump on a soapbox, but medicine's an art, not an algorithm.
Yeah.
And too often we train the algorithm, and it's like, well, the guy said, 50 milligrams IM ketamine, like he got it, and like the patients, all our training patients just like fall into place when you follow the algorithm. Yeah. And, disaster happens when you step out of it.
Yeah.
That's not how life works.
Yeah. I always tell people too, is like when you see the algorithm, this box, then this box, then this box, and this box, all the really interesting stuff happens in between the boxes, but no one ever wants to talk about that, kind of a thing. It's like, yeah, the boxes are great in the beginning. They give you some kind of a guideline, but it's just a guideline, like, kind of like the pirate code, Pirates of the Caribbean. It's a guideline, all the weird, stuff is happening between those boxes. And that's where experience really does come in, to know like, hey, what's going on right now is not one of the boxes to choose from. You know what I mean? What do I do now, kind of a thing? And that's where, training comes in, and, doing things like that, just talking, like, talking through things, before they actually happen. Oddly enough, one of my great people in life that I've ever had the chance to know was Brian Burlingame, who's a fantastic surgeon, deployed with him many times. And, we used to play a game when we were deployed, and the game was we would create the injury pattern, so to speak, and talk about, and now it's just come through the door. What are we going to do? And you know what I mean? And it was like, I would do this, I would do that. And so just that talking through, those events, whenever things would happen, would drastically improve the reaction times of the team, because you'd already in your mind played through some of those things. Now you're not going to see the exact same thing, but close enough, that you've already talked about a lot of those things, and now you're working together, not working against each other, kind of a thing. So I know another soapbox, but yeah.
No, very good. Very good. Well, I appreciate it, Brad.
Yeah, dude. Anytime, man.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.